back to your question on how I plan to streamline KEMSA. Having interned there, I have a view of what it is that happens at KEMSA as a public institution. And as I said, I also worked at MEDS, which is a faith-based institution. And what then I bring to KEMSA, which I'm sorry to say, but most of the public institution, there's some laxity in terms of operational efficiency. While there, I realized we had a problem with quantifications, how they arrive at what they buy for patients. And at MEDS, quantification was almost accurate to the point. How did we do it? Is that we got to know the needs from the faith-based institutions, faith-based facilities. Early in advance, before we did our tender process, we could find out from the hospitals what their requirements were. Based on that, then we worked on quantification. At KEMSA, they do a push system, where then the stocks are pushed down to the facilities. And the facilities are supposed to be pulling from KEMSA. So the push system then means quantification is done at the top, at KEMSA level. And I'm happy because in Kenya Kwanza we are talking about bottom-up. Therefore, the facilities will be bringing up their quantities. Based on that, quantification is done. And that is why you hear at KEMSA right now we have expiries, we have obsolete, is because of poor quantification. So we shall start right by supporting KEMSA to ensure that they do proper quantification for products. Regarding cost of drugs, is again because of not quantifying properly, you end up buying wrong quantities at the wrong prices. But more importantly, my suggestion would be like, we do more of local manufacturing. We have molecules that can be manufactured in Kenya. For example, I'm yet to understand why we still import paracetamol. Yet we have companies in Kenya who are manufacturing paracetamol. If we were to buy from these locally manufacturing companies, definitely the cost of paracetamol will be much lower than the imported one. Honorable Kimani, the issue of community health workers in this country is that there are some success stories with community health volunteers. And I'll give an example of Kisumu County. They are moving on very well because they are giving stipends to their community health volunteers. And because this universal health care, they were doing some tests on a number of counties, then we should learn from the success stories like the one for Kisumu, just to find out how has it worked. Then that is what we can move to the rest of the counties within the country, that these community health volunteers then get a stipend, and it can be done on a matching basis, that as much as they are employed by the county governments, then the national government can match that stipend, just to, to make them do more work. Then you spoke about the 2021 healthcare workers, and members through the chairs, you may know, as much as health was devolved, on Schedule 4 of the Constitution, there's distribution of functions. There's what was left with the national government and what went to the county governments. Recruitment of healthcare workers, most of it is happening at the county government. So then I shall be working with the county governments, and it's supposed to be collaborative. And I am aware there are structures that have been put in place to ensure that the county governments are able to work with the national government. Then is to ensure that these healthcare workers are absorbed in their respective counties. So I may not be able to say that we shall give appointment letters, but once that discussion has happened, and I pray that this committee is able to approve of my nomination, then we should be able to work together to ensure that the workers are absorbed. As we know, most of the facilities in this country are ill-equipped. Even with the healthcare workers, there is a shortage.